Hi, everyone. Thanks, Vivian. As Vivian said, I am Michelle Kearney. I'm a doctoral prepared nurse practitioner, and as the clinical training lead at Viz here, I'm responsible for the development and delivery of clinical education content and training. So before Viz, I spent 20 plus years as a nurse and a nurse practitioner. I've been an IR nurse, an ICU nurse, stroke coordinator, and a research coordinator. And in the last 12 years, I actually spent most of my time as a stroke NP, and I have cerebral vascular interventional expertise. So thanks again for joining us today, and let's get started. So first, today we're just going to really talk about what stroke is, what ischemic stroke is, but mainly why it's important and what we can do about it. And we'll focus a lot on some imaging. And let's just start with defining a stroke. So a stroke is a sudden impairment of brain function because the blood flow to a portion of your brain, portions of your brain has stopped. And that can either happen because there's a plaque causing a blockage of the blood flow into the brain, or maybe a clot came from somewhere else, like your heart or someone's aorta, and it blocked off an artery feeding the brain. Or you can also have hemorrhagic strokes, which can happen in subarachnoid hemorrhage when maybe an aneurysm or an arteriovenous malformation happens and they rupture, and all the blood will be then in your subarachnoid space. Or you can have hemorrhagic strokes inside the parenchyma or body of the brain. So if that happens, it's usually because an artery is fragile and it's torn, and now the blood is actually inside all of the brain tissue. Today, we are going to concentrate mostly on the ischemic strokes. But either way, just so you know, the facial droop, weakness on one side of the body, slurred speech, confusion, changes in your balance, or even dizziness, vision changes or eye movement changes can happen in either stroke. Headache and loss of consciousness is also something that happens in either type of stroke. But a lot of that headache and loss of consciousness happens in these hemorrhagic strokes. A loss of consciousness in ischemic stroke is usually really bad. So it can have really poor prognostic signs because it's in your basilar artery often. So what about globally? So over 110 million people in the world have had some sort of stroke, and 1 in 4 adults over 25 years of age will actually have a stroke, an ischemic or hemorrhagic stroke in their lifetime. That's 12.2 million new strokes per year. And there are actually globally 7 million annual deaths, and that was in 2020. And that means that 3.48 million of those are actually from ischemic stroke. The others would be from both of the other types of hemorrhagic stroke. In the United States, there's a stroke every 40 seconds, and there's a death about every 3 minutes and 17 seconds. So it's still the 5th leading cause of death here. It is our number 1 cause of disability. And that in 2020, it cost us $34 billion. And that included our medicines, work days, services, all the services we offer to help somebody get over a stroke. And then there are big disparities in stroke. And so there's something called the stroke belt, and that is here. I live in Nashville, Tennessee, which is right here. I kind of feel like it's in the belt buckle of that. So the darker the purple, the higher the death rates from stroke on this map. So we might have really great food down here, but we certainly have some repercussions from that. And also, Black individuals are 2 times higher risk to have strokes and have the highest death rates. And then our Latino and Hispanic populations are having increasing death rates over the past few years. A lot of this in the South, in the stroke belt, is linked to a lack of access to care. And we'll talk about that just briefly. It's really important, right, that people have access to care, because for every minute in a stroke, you lose 2 million neurons. That's 14 billion synapses, and that's 3.6 years of your brain age. So for every hour, you're losing 3.6 years of your brain aging. And then the better outcomes come with faster interventions. And what I mean by that is this is a simplistic view of what a stroke pathway could look like. But here at the top, you see that somebody's had a stroke. You hope, ideally, they would call 911 and get EMS. So EMS comes and they bring them to the hospital. And now once you're in the hospital, an ED provider will assess you to say, oh, yeah, there's some sort of neuro event, and then usually order some sort of imaging. We start with a non-contrast head CT, move to a CTA and a CTP. And then once that is read, the radiologist will call the ED provider, whoever ordered it. And then that person says, oh, there's a stroke. Then they have to call the neurologist, and then the neurologist then evaluates the patient and the imaging. And if they think that they're a thrombectomy candidate, then they call the neurointerventionalist or interventional radiologist, and then they have to get the team together, which makes it hard to meet these goals. So for stroke, there are very specific guidelines. We in door to needle in 30 minutes. We like a door to artery, and that door to needle means thrombolytic. Door to artery means, hey, we need to get to the start a thrombectomy. We like that to start in 60 minutes. And we would like a device up to the clot in 90 minutes. So all of this is really difficult when you look at the workflow. So let's just talk about those pathway goals. So a thrombolytic is a medication that will break down the fibrin of a clot that's blocked the artery, and the patient is ideally treated within 3 hours of onset. There are a lot of studies, and we'll talk about that in the treatment section, that have indicated that we could do this a lot farther out. But this is the whole goal, is to kind of break down the fibrin of that clot. The other thing we like to do is the thrombectomy. So this is the door to artery, door to device time. So what you're looking at on the screen is a long catheter. It's a kind of a really narrow tube, and they either access the femoral artery or a radial artery, and then the catheter is floated up through those the other arteries into the brain to get to the clot. On the view here is a stent reaver. So if you think about that as a stent on a stick, you get that into the clot, it incorporates into the clot, and then after the longest 3 to 5 minutes of your life, you pull this back out. There's also an aspiration catheter that looks very similar, but it's a hollow tube, and you put it up next to the clot and kiss it essentially and suck out the clot. So these are the two things that we're aiming for. Unfortunately, not every place can do this. So when we have stroke certification and stroke centers across the country to help this out, but you still have that basic hospital, which is your assessment, your ID, your stabilization, and transferring someone. And then we move up to acute ready hospitals, acute stroke ready hospitals. These places have thrombolytics, CT scanners, and usually acute stroke expertise via telemedicine. And then moving on up, we have stroke units in a primary stroke center. So you get to keep the patient there. There's a stroke coordinator often. There's a whole stroke service and a continuum of inpatient care, such as rehab. They have rehab, and they can help you with social work and lots of things. And then a lot of these primary stroke centers were actually doing thrombectomy as well, but didn't have a certification for it. And maybe they didn't have neurosurgery on call. So if you see up at the very top is the comprehensive stroke centers. So they have all the functions of below, but also have full-time neurosurgery and a lot of that hemorrhagic treatment that they can do. So what we have now is a thrombectomy capable center, which is a primary stroke center that's certified to also do thrombectomy. Unfortunately, there is still some disparity, right? So if you look here on the right are the stroke centers updated last in 2019 and written about by Bogle and Boggs by 2022. And you can see that they're scattered across the country, but there's some states that have zero. Again, here's that stroke belt with that deep purple. And I, again, live in Nashville, Tennessee. So in these big centers, we have a lot of comprehensive stroke centers. I live within 5 miles of 3 comprehensive stroke centers, and 45 miles outside of Nashville, there aren't any. And then if you kind of move on out east or west or south, there are really no stroke centers. And so we still have a lot of disparity moving that. The only good news is that recently we figured out that at least 90% of people in the United States are within an hour of one of those acute stroke ready hospitals, but we still have a lot of work to do. So let's just talk quickly about strokes and its epidemic and what happens in the brain. So brain anatomy, every lobe and section of the brain has a very specific function. So you can see here we have the frontal lobe. That's important for our smell, our judgment, foresight, voluntary movement, and that filter that keeps us from saying things we don't really want to say, and all of that inhibition that we need. And then we have the motor cortex and your sensory cortex behind that, and then the parietal lobe, which helps keep our attention and also our spatial awareness. So these can be people sometimes who can't figure out how to put a glass down on a table, that sort of thing. And then then we move into the temporal lobe that has our speech and our language. And the difference between speech and language is speech is how well we speak. So if your words are slurred, that's a speech problem. I can have very clear speech, but also talk nonsense or not understand what someone is saying to me. And that is language. So those are the difference, but they're both here in the temporal lobe. And it also is where our intellect stored, our perceptions, and then language and memory and learning. And then we have the occipital lobe, which is our vision center. So often you'll hear this be also called the posterior area of the brain. So it's in the vision is in the posterior sections. And then we have posture and balance through the cerebellum, and the pons is our homeostasis, or it maintains our life. So that's our brainstem. The other thing we don't always talk about in stroke, and I feel like we do a really great job of talking about this in cardiac and other areas, are vascular territories. So just to talk about that a second, I've turned my video back on so you can see my 3D model of this. So we're often taught that the circle of Willis, which is are the large vessels that feed our brain, looks like a spider. And I guess when I got this 3D model, which I do love, it does sort of look like a spider. But if you're looking at me, this would be my carotid artery. So my internal carotid artery goes up, and then right behind your eyes is something called the middle cerebral artery. And that artery is really invaluable, and it feeds a very large territory. So if you put your thumb up next to your eye and kind of stretched your hand out, you would know that the vascular territory fed by the MCA is really, really large. And you can see that here also on the screen. So when we're talking about the anterior circulation, that's these, and they run anteriorly to my to the brain, so anterior section. And then you see that it takes in your frontal lobe, some of your motor and sensory cortex. And then this MCA territory is that really large territory. And then there's that posterior cerebral artery. So this is that occipital area, or that posterior area where your vision is. So that is linked by a little circle here, and it goes back to your back. So your posterior cerebral artery there. And then what we have then next is our vertebral arteries, called so because they go up our C-spine. They join into the basilar artery, and then the brainstem is inside of that, if you can see that. And then the cerebellar arteries are the ones that branch off the back. So, it's just really important to know that our brains actually have vessels, right? We don't always think about that. And so with that, here's another image of that. So what's really important is the MCA, because when we started these thrombectomies, a lot of it was in what we call the anterior circulation, so this front part, and then these MCA. So these were large clots. And again, if you have a large clot there, it can be pretty devastating. And to show that, I will just so if you have a blockage here in your carotid artery, you know that all of this territory distal from that is going to be at risk, right? So if we don't do anything, that this whole part of your brain would die on the side that's affected. And then here is your middle cerebral artery, and we've already showed you, if you have that blocked, it's going to take out all of this territory. If you block off your anterior circulation, your anterior cerebral artery, you're going to have problems in your frontal lobe, your motor cortex, your premotor cortex, and your sensory areas. And that a posterior circulation stroke is going to take out some of that vision. And if you have one here in the basilar artery, or even blocking off some of the cerebellar arteries, you're going to get brainstem problems and dizziness, et cetera, from the cerebellum. So that is why we came up with this acronym. We were doing pretty good we know that when you have a stroke, your face can be uneven, your arm might be weak or numb, your speech could be slurred, and it's time to call 911. So for a long time, we used FAST. But remember, I said we have cerebellar strokes, and you can be dizzy, and then which is a loss of balance, or you have posterior circulation strokes that can affect your eyes. So we added that to be BFAST, so balance, eyes, face, arm, speech, and time. And I would say that those hemorrhagic strokes are going to have that terrible headache, which could also be a T. So looking at all of those things together, there are a couple of just some key points that if you have a stroke in one of those territories, it's going to knock off the territory. So if there's a blockage in one of the vessels, it's going to change the way the territory functions. And then if you have a stroke on your left side of your brain, it's going to affect your right side. And if you have a stroke on the right side of your brain, then you're going to have a lot of left-sided symptoms. So what happens? Why does this happen in the first place? So, in addition to these listed here, there are others, but in 1993, we actually described categories of ischemic strokes. So, we categorized them as large vessel disease strokes, small vessel disease, cardioembolic, cryptogenic, and other. So, the large vessels, going to just think about that as those large vessels I showed, the carotid artery. That happens because somebody has a lot of lipids, or maybe you have a dissection, and that leaves a little flap and tears the vessel, or maybe small vessel diseases because somebody has a lot of hypertension and hyperlipidemia, tobacco use, and diabetes. And then cardioembolic means AFib, aortic atheromas, or maybe there's a valve that has a vegetation on it. And then sometimes, actually, a couple of times in my career, people have come in with cancer only to find out that they actually have stroke, because cancer can make somebody have hypercoagulability or be more likely to have clots. Believe it or not, 30% of the time we have no idea when somebody has a stroke. So that could be, we often think it might be a atrial fibrillation we haven't seen yet, or maybe a PFO or some kind of other thing that we have to continue to investigate while they're in the hospital. So looking at that a little bit closer, this is what would be an cardioembolic or embolic stroke. So you can see that the heart here might have AFib, or there might be an aortic arch atheroma. And in AFib, it puts people at high risk of strokes because the atria just beat out of rhythm and kind of however they want, and often fast. And we've always learned that there are 4 chambers of the heart. Well, at the top in those atria, there are these little appendages off, and blood can kind of get caught in there and just stay. And when it does that, it starts to clot together. And that makes a really thick fibrin clot. So that could come over here. This would be your internal carotid artery, and it could block off, in this example, your middle cerebral artery, right? So that's coming off here. This is your anterior cerebral artery, and this is the posterior cerebral artery. But if you have this fibrin clot, all of this is going to be at risk here, right, of dying. So now we've got this ischemia starting. When we had that circle of Willis, think back to the model, they were all connected. And that helps us have something called collateral flow. So this is our ACA, it's still feeding this area. And our posterior circulation is also, but the PCA is also feeding this area. So it gives us a little time. The other thing is, you can have this large vessel disease. So that would be like a carotid artery that's really clotted off with plaque, or small vessel, which I always found to be a misnomer. And I always talk to patients about that, because you hear, oh, you had a small vessel stroke, but your family member looks really terrible. And it's not that it's a bad, like an easier stroke. It just means that these vessels are not large that had the stroke. So you have the MCA that comes off, and as they go distally, they get smaller, but these are called leptomeningeal arteries, and they are very tiny. And with diabetes and hypertension and tobacco, they get really friable, and they get, this is often an area for hemorrhage as well. But this is your air traffic control area of your brain. So even though this is a small vessel stroke, it's not a small stroke. What about a TIA? I get this question a lot, whether or not a TIA is a stroke. And I'll say that I feel like if you think about a TIA as a stroke that didn't leave a mark, because when you do an MRI on someone after they've had a TIA, which is this focal dysfunction that lasts about 10 minutes, and it could look really bad. So if somebody loses all of the function on one side of their body, it often means that their carotid artery has a clot in it, and maybe it's getting a thrombus on it because plaque gets sticky and then the blood sticks to it, and then maybe the thrombus flows away. But that is often a real harbinger of a big stroke. And a third of the patients who have TIA will actually have a stroke in the next 5 years. We still do the same workup, but you can imagine that you don't actually, when somebody's doing okay because they've had this small stroke that goes away, we don't do thrombolytics, and we don't, obviously take them for a thrombectomy. But the whole goal is to maximize their medical management and figure out why they had the stroke so we can keep them from having another one. So this is Victor, and Victor is going to help us get through the rest of our time together today. But he's a 67-year-old man with a history of high blood pressure, diabetes, and he came to the emergency department with slurred speech, left facial droop, left-sided weakness, and he was out riding his lawnmower. So his family thinks these symptoms started about 3 hours ago, because that's when they went out that's when he went out to mow the yard, and they've now found him 3 hours later. So physical exam, when he gets to the hospital, he has severe dysarthria. So that means he's got speech problems. He's slurring his speech. He has left facial droop, left-sided arm and leg weakness, and something called left hemisensory neglect or loss. So that means that these folks, when they have a stroke here, kind of don't notice their left legs or their left sides. So it's very interesting. These people also will not see, like if you put a plate down, often they might not see one side of their plate. So let's just do part of that interaction now. So with Victor, which side of the brain do you think has been affected, his left or right, and which territory, thinking about the model and what we talked about earlier, has been affected? Is ACA, is anterior circulation, middle circulation, posterior circulation, or all of those? Yeah, exactly. He's having only symptoms on the left side, which means that this is a right-sided stroke. So he's having a stroke on the right side of his brain, and it's at MCA territory because it is so, it covers a lot of that area. So that is most likely what he is having. And what facility do you think he should go to? Which facility type? The Comprehensive Stroke Center, the Thrombectomy Certified Center, the Primary Stroke Center, or Acute Stroke Ready Hospital, or the closest? Yeah, this one's always tricky. It's kind of my favorite because it gives us a chance to talk about this. Um, every state, every city, every county seems to have a different EMS protocol, but it helps. There are a lot of stroke protocols in place. And the goal, of course, is to beat time, right? So you do want to get the patient to the best place possible in the best time. But the American Heart Association, Stroke Association have said that if you're within 30 minutes of a comprehensive stroke center and you've got a big looking stroke like Victor here, based on some of the EMS assessments, you should go there. But if you're outside of that 30-minute window, it might be best to go to your closest center, regardless of what time, so they can get them where they need to go. So when he gets to the hospital, now we have to do some stroke scales. And that is going to be, our NIH. So if you've heard of that, that's a National Institute of Health Stroke Scale score. And the higher your number there, the worse off your stroke. So a lot of neuro things are like that. The higher your score, the worse off you are. But it's on a 42 point scale, and in 21 to 42 would be severe. And of course, 0 would be no symptoms at all. And then minor strokes are 1 to 4, moderate 5 to 10, 5 to 15, and 16 to 20 are moderate to severe strokes. It's good to know that the higher your number, the worse your outcome is likely to be. And it tests your level of consciousness when you come in, whether or not your eyes are moving in the same direction, or maybe you have no vision. Test your face. Is it equal, motor, sensory? And then that speech and language. And then something called neglect, like Victor has. The other thing we want to know before we start doing things to people is what their modified Rankin scale was before. And this is before they get to the hospital. So this is before you see Victor. We want to know, how disabled was he? Because if he actually was bedbound and had severe disability, it's hard to say that something that we can do for him will make him better than this. We certainly want to get somebody back to normal. So a lot of times, we like to know how disabled somebody is. And that can be hard to distinguish. So given that, we have done Victor's NIH. So we know he's a 12. So he's got a moderate stroke right now. What do you think his modified Rankin scale is? Is it a 0, 1, 2, 3, 4, 5? We know it's not 6. We use that scale also in studies and when patients leave the hospital, and maybe in 30 days, so that we know how well they're doing and if they're back to normal. So we do include 6 because that, if someone dies, we would like to know. But Victor here has an NIH of 12. And what do you think his modified Rankin is? Yeah. So he's a 0, but this is hard to tell because you don't know. I haven't told you much except that he was out riding his lawnmower. But, if somebody is out riding using their lawnmower and the family knew that was okay, then we're going to assume that Victor's a 0. And then next, who would have a better chance of being back to normal in 30 days? Is it going to be this 48-year-old man, this 48-year-old who has an MCA stroke affecting their brain with an NIH of 17, or a 70-year-old who has an MCA stroke affecting their brain with an NIH of 5? given what you know about what the NIH can mean to someone. Yeah, again, so what we know is that the higher your NIH, the less likely you're going to have a good outcome. So even though this person's 48, the 70-year-old is probably going to do better because their NIH is only 5. So good job. So we'll move into now what we do after we've done these assessments. So what's the next thing to do? Well, it's imaging, right? The entire goal here is to save dying and at-risk brain tissue, because when you have a stroke, there's going to be a part of it, your brain, that just dies because the blood flow to that area has stopped. But remember collateral flow, right? So the MCA could be blocked off, but you're still going to get some blood flow from those other arteries. So what we call this is the ischemic penumbra. So this is ischemic and not quite dead yet, but this would be core. Now, if we leave this person alone over time, you can see that it will just continue to grow. This ischemic penumbra becomes more and more core. And if at 24 hours we've done nothing, that whole area that was at risk is now going to die. So our whole goal is to save that. And stroke's an imaging algorithm. And I think that's why it's so important to include a radiological technologist in this, because we depend on you to get all of this imaging for us to make these big decisions. So in that algorithm, is this a stroke? We do these assessments. And the next thing we want to do is a non-contrast head CT to see if there's a bleed, and then a thrombolytic, because if there's no bleed, we could probably give them one of those thrombolytics. And then we're going to do a CTA because we'd like to look to see if there's a large vessel occlusion. We're going to look at what we call the plumbing there. And then the MRI and the CT perfusion helps us know how well the brain is reacting, or the physiology of that. And then what about a thrombectomy? All of this helps us know if somebody should go to the interventional suite to get one of those thrombectomies to remove the clot. So the parenchyma, the plumbing, and the physiology is what we're worried about here. So we go to that non-contrast head CT first because it helps us know if there's hemorrhage, because there are 3 things white on a CT scan, right? Blood, bone, and contrast. And I've told you that this is non-contrast. So the only 2 things that are going to be white here are going to be blood. And this is what a hemorrhagic stroke would look like inside that parenchyma. Or here you can have the skull, which is white. Here you have something called a hyperdense MCA clot sign. So if there is a big clot blocking off the MCA territory, sometimes you can see it on the plain CT scan because the blood is showing up. The other thing that we really use the CT for is to see if there's damage already. So if we don't know when somebody was last known normal, say Victor has just been down there forever and a neighbor found him, and within 6 hours, you'll start to see changes in this brain. So here's that clot. Right now, you compare it to, this is his left side, this is his right side, and they look about the same. That looks okay. But over time, you can see that now this side is losing some of that gray and white differentiation compared to this side. And now it's all isodense. So what we're seeing is this is now no longer viable tissue at all. And it is now turned into a complete core. If you re-image somebody later, this is what we call a chronic infarct. It's hypodense, it's dark and black. And this is a chronic infarct. The other thing we use that CT score for is something called an aspects. So you might hear somebody say, well, the aspect score is 1, or the aspect score is 10, or it's not good. What we use that for is a radiology tool. So it segments parts of that MCA territory. Remember how large that was? So for every part that's affected by the stroke, they take out a point. So 10 is the best you can do. And then for every region, you subtract it. And so a lot of times for guidelines of thrombectomy, you would really like it to be at least 6. You don't want more than 4 of these regions to be gone. But we continue to do some imaging just to see. If it's more than that, a lot of times the response and the prognosis is poor. The only issue is that we can't tell what is penumbra, right? Which is ischemic, or what's really core already. And most of the centers in the United States use CT perfusion. The Canadian centers do use aspects a lot, and it only works for an MCA stroke, so not all of them. So what is the best interpretation in your mind of this non-contrast at CT? Is it an acute MCA territory infarct, a subdural hematoma, which is a hemorrhage, a chronic MCA territory infarct or intraparenchymal hemorrhage. Yeah, so this wouldn't be acute because you might not see any changes when it's really right acute, but it's going to be chronic, right? This is all dark. It's hypodense now, looks really a lot like the ventricle. So this is a chronic MCA territory infarct. So this is Victor's non-contrast head CT. What do you think is happening here? Do you think he's having a stroke? Yes, no, you're not really sure. Yeah, so this one can be tough, right? If what we do know about Victor is the good news here. So this is what happens a lot in the CT scanner. I'll be down there and I'll say, oh, the CT's negative, and somebody who's maybe new to stroke would say, oh, so they're not having a stroke. And you say, no, they're having a stroke. He's got all of these symptoms, looks like a stroke, smells like a stroke. He's having a stroke, but he doesn't have damage yet on that CT scan. So acute strokes sometimes look like this, and that's great for Victor, right? He's having a stroke, but we don't see a lot of damage on that CT scan yet. So that's good news for Victor. So next we want to know about his plumbing, right? So we're going to do a CTA, and that's going to tell us a lot if maybe there's a large vessel occlusion. Maybe one of those big vessels we talked about with the model is occluded. So what we do in a CT scan is that we give IV-based contrast, and then we time it for a single phase CT to just highlight these arteries. And it's widely available. It usually only takes about 5 extra minutes, and it can help us find arterial occlusions. It can help us look at that collateral flow. So you see here, this is the MCA. This is the MCA flow outside of there. This would be the ACA, and it's coming out. And so this, for Victor, he sure enough is having a large vessel occlusion. So this MCA here on the right side is blocked off, but he's got, you can see, you'll see some vessels here. So good news is he's got one, his CT looked okay, and he's got a little bit of collateral flow. So we hope that we have some time. You can also get 3D images of the neck and the intracranial vessels from a CTA. So now what do? We know what his scans look like, and we know what his assessment looks like. Well, in 2019, they updated some of the 2018 guidelines to tell us when we should maybe do a mechanical thrombectomy. So some of it's easy. So we, whoops, I went too fast. So we use it for like type 2 and 3 segment occlusions after 6 hours. In selected patients, now up to 6 to 16 hours. If it's in that anterior circulation and they meet specific criteria, then we know that it's recommended. In select patients, we can actually do it up to 24 hours. And patients aren't really numbers, right? So we're pretty liberal with this. What we learned is that time shouldn't prevent us from making these big decisions. So we've used imaging. And what that means is that we're looking for that core, remember, what that is, that dead brain, and maybe that penumbra. What can we save? So what is that mismatch on CT perfusion? So they say if the core is less than 70, you should treat it. And if there's the mismatch between the two of them is more than 1.8, and then there's only a penumbra of at least 15, you should go ahead and treat someone. And if for a little bit we were running patients right into these endovascular suite to treat them without giving them TPA. So here's where they're saying, no, if they're in the window, you should still give them thrombolytic. So the word penumbra actually means the place between darkness and light. And so I'll say, oh, well, I sort of think that means between core and ischemic tissue. So again, the CTP is looking at the physiology of the brain. How's it reacting? So it evaluates the blood flow. It helps inside that parenchyma, how well it's flowing. It helps find any occluded vessels. It can help us manage who can get some thrombectomy. It's fairly widely available. And even though MRI would be the golden standard for this, it's historically cheaper than that and easier to monitor patients. So what happens is we inject contrast and then image a portion of the brain repeatedly over time. So that gives us these different maps. So here, if this is something called relative cerebral blood flow volume, which we'll talk about, and cerebral blood flow. So even if you're just looking at this, you can see that, wow, these areas look a little different. And that's because this dark blue means there's less volume of blood per brain here, and the flow of that volume of brain is off here compared to this other side. And then the other thing we see is, hey, this is mean transit time, or how fast the contrast is moving through. And compared to this other side, we've got some real problems on this side. So it makes a lot of these maps that we look at, and it estimates what's at risk, or what that ischemic penumbra might be, and what's actually estimated to be core, already dead tissue. So with that, we actually have the cerebral perfusion pressure of your brain, right? We have to have so much perfusion in our brain to make it function, becomes this relative blood flow that I just showed you on that map. But normally a brain perfuses pretty good between 6 and 100, right? So this is going to be a pressure gradient made from your blood pressure, et cetera. But anything under 60 is hypoperfused, so it's not perfusing. In that, sometimes people are still doing okay. But once you hit 30, brain death starts. So that's why we use that as core infarct. So once it's less than 30, then brain cell death starts. And inside that, you've got this ischemic area too. Some can be saved and some is already dead. So again, this dark section is what we're looking at. Our whole goal again with this is that we would like to save as much as we can, and something that the best patients are the ones with the smallest core and the largest at-risk territory. So that mismatch hypothesis is what makes this work. But at-risk territory here, we'll look at this curve because that will help us work through that. But here, the CT perfusion is really a bunch of curves that analyze the passage of contrast through the brain, and those quick segments, right? So you can see here the contrast is injected. It goes up through the arteries and then back out the venous system. This all here under here is the cerebral blood volume. So how much blood volume did you see in this area of the brain? And then that helps us know what that flow is too. Like, how long did it take this blood flow to go through? And then we look at the Tmax. So this mean transit time is also, so you can just imagine that the worse off the brain is, the slower it's going to uptake the contrast. Or maybe there's a blockage and it's just slowly dying. So it's not moving through really quickly. And that helps us know what's at risk. And that's what this map shows. So which of the following is a predictor of relatively better outcomes in ischemic stroke? Is it going to be an aspect score of 1? That was that radiology tool, 1 of 10, an NIH score of 31, or large collaterals? Which of these would be a predictor of better outcomes? And I ask this because when we're looking at CT perfusion, we're really wanting to know how well is the brain, again, responding, and what's at risk and what is core. So if there's still a lot of collateral flow, then you're talking about, hey, we've probably got more at risk than we do core. So good job. So let's go back to Victor here. So looking at him, we have an ischemic score. This is when the guidelines tell us to treat, but don't memorize these because, of course, patients aren't numbers and we want to treat them the best we can. So the core is going to be that cerebral blood flow less than 30, and the Tmax is going to be the at-risk territory. So when you're looking at this perfusion summary map, this is going to be the core. It's 54 cc. So all of this red here. And then when you're here is the Tmax greater than 6 seconds. In normal brain, it's only 3 seconds, right, to make sure that this gets through the brain. So greater than 6 seconds is ischemic, and that's 91. So to get that mismatch volume right here, it's just 91 minus 54. And if you want to get that mismatch ratio, or how much penumbra to core we have, or tissue at risk, then that is going to be this number. It's just going to be our 91 divided by 54. So knowing what you know about Victor and all of his other scans and this information, is he a good mechanical thrombectomy candidate? So it's hard to know. because he doesn't meet these criteria just perfectly, right? He's not better than 1.8 on his mismatch, but he's got a lot of penumbra here, and he's got some core. But again, people aren't numbers, and we've seen his non-contrast head CT look pretty good. He doesn't have a lot of damage, and he's got a large vessel occlusion. So he is a good mechanical thrombectomy candidate. So there are limitations to that CT perfusion: motion, implants, cervical, intracranial occlusions. So you can imagine if some of the vessels are really tight, that blood flow that we're watching on that curve can be off, and that's how we get our maps. And also, if there's poor cardiac output, like an MI or something, or a really small IV access, or someone mistimes that contrast injection, or there's a really slow injection rate, or maybe the IV infiltrates, all of these can really limit how well we can, how great those curves are and how good the maps look. So here's just a quick look at those. So here is a good curve. Remember, this curve kind of looks just like the one we looked at earlier. So the arterial inflow and the venous outflow here, this is really no issue. We can probably trust all our maps. This, where they're the same, there's a problem usually with cardiac output. So we'd have to be suspecting something off about that scan. And if there's a whole lot of excessive motion, you can also see that. So if the maps don't make sense, a lot of times we look at this, but you can see that there's not a lot of motion on this one, and there is on here. So you would really worry about some of these off maps. So which of these can limit the usefulness of CTP? Is it a patient who's moving around, a patient with heart failure and low cardiac output, a patient with a small bore IV catheter, or a patient who has a metal implant in their head? You can check as many as you think. Yeah, it's all of those. Good job. So next, like I said, that the MRI was the gold standard. And why would we use a CT if the MRI is the gold standard? Well, you can probably guess, but the MRI is great because it can distinguish old from new infarcts. It won't just do perfusion in that one specific area like the CT perfusion. There's no ionizing radiation. There wasn't a contrast shortage for MRI a few years ago. The new decisions for all our late window treatments are actually based on MRIs a lot. And then we can look at that posterior circulation a lot better than we can. And if it's a mimic, maybe somebody's having seizures, or maybe there's actually a tumor that we don't know about, it's really better at detecting those. However, the multimodal CT scans are fast, right? They rule out acute bleeds for us really quickly because there's a very different pathway. We can monitor patients a lot easier. If there are really no contraindications for that non-contrast head CT, it's better available and the staffing is easier. Also, even as a provider, I'm just more comfortable reading these CT scans and making stroke decisions because all the pivotal stroke studies we used were based on CTs. So if you did want to know if somebody was having a stroke based on your MRI, you would look at your DWI and your ADC maps. So the DWI is that diffusion weighted imaging. So it's the random motion of water molecules. When there's a abnormal diffusion, you actually will see it here as bright. So that diffusion of water has been affected by the stroke, and so it will be bright and abnormal. The ADC map is going to kind of tell you how abnormal, what the magnitude of that diffusion is. And so it is dark when it's abnormal. So if it's bright on DWI and dark on ADC, it's a stroke. If it's bright on both, often it's some sort of artifact, but we look at the DUI and DWI and a few other maps. So some of the common treatments we use can always be a little difficult, right? We're worried balancing is difficult. So we have intervention for penumbra, right? That ischemic penumbra, we need to treat it. Intervention's not indicated for core. Intervention is not indicated for oligemia, which just means somebody who's completely asymptomatic. If somebody's asymptomatic, we could do more harm than good. So back to our acute pathway, our whole goal was to see if we needed to do thrombolytics and maybe we needed to do a thrombectomy. So the thrombolytics I told you broke down the fibrin clots. There are actually two types that we use. There's IV alteplase, which is TPA, which has traditionally been the one that's been used in the last 20 years, and then IV tenecteplase or TNCase. They both are being used within 3 to 4.5 hours, though their FDA approval is for 3. Tenecteplase, I'll just say, hasn't been FDA approved, but there are a lot of studies that support its use, and a lot of centers are using it. And in these unclear onsets, so people don't know when their last known normal was, they suggest that we could still give these thrombolytics in those late windows. The biggest difference is that the TPA is delivered in 1-minute bolus with a 1-hour infusion. So that means you have to have 2 IVs if you're doing CTAs. There's a lot of checkoffs. The IV tenecteplase or TNCase is delivered in a 5-second push. So as you can imagine, logistically, this is been shown to have the same outcomes, no more bleeding, etc. And so all of the centers near me are actually on tenecteplase now, just because it's a 5-second push. You don't need second IVs. It doesn't slow down the process. And then that thrombectomy I showed you earlier was the stent retriever. Here is that aspiration catheter. So it's a larger bore catheter, and it goes right to the clot and often has some sort of suction attached to it, and it will pull out the clots. And here are a couple of clots that we've pulled out of the brain. So we did take Victor on to the IR endovascular suite, and this is what he looked like before. So this is the coronal view of him. So this is the right side of his brain, and you can see the skull, and there's some stuff missing, right? We've got some vessels missing. So we went ahead and pulled that clot out, and now he's got all of the MCA territory flow back. And this is the sagittal view of that. Again, remember, had that large MCA territory we talked about at the very beginning of our time together. And now, once we've removed the clot, we have that revascularization there. And we give those Tiki scores. So what about our CTP? Did it really predict what he might look like? So remember, we had a lot of core, he had a lot of penumbra, and we said, you know what, he looked pretty good. So let's take him. So often we do an MRI the next day to see how well someone is doing. And sure enough, this DWI is bright. So he's had this stroke, right? And it matches a lot of this core area. The good news is, because this green will often include this core, right? He doesn't have strokes that are this big. So because we were able to get to him and give him his treatments, we've actually decreased his core stroke infarct. So now, after somebody's had the stroke, like I said, we try to investigate why they had it. And if it's high blood pressure, we do antihypertensives. If it is cerebrovascular abnormalities, maybe they have a really tight carotid, then you might need a vascular consult. Everybody gets an antiplatelet like aspirin or Plavix, most everybody. If you're smoking, we tell you to stop. And then most everybody gets a statin to keep their lipids at bay. Treatment for their diabetes and if we don't know why, remember, if you have AFib, we put you on medicine, but there was 30% of the time we didn't know why. So somebody might need some of that prolonged monitoring. And then if it was cancer, then we're going to need, or cancer or some other issue, then we're going to need some consults and referrals for that. Quickly on that workflow. So let's remember what the workflow looks. So this is our typical workflow. Remember, we have these door to needle, door to artery, door to device times, and this phone tree, right? This phone tree. So a lot of folks ask what AI means and what it means in stroke. And so what it means in stroke, I'll just show you what happens if you have delays. So this is a patient of mine. He was an inpatient stroke alert about 35 miles from here to Primary Stroke Center. I work at the Comprehensive Stroke Center. He had the stroke. His first CT set looked pretty good. So CT negative, not a lot of damage. There was a large vessel occlusion on that CTA, and he needed alteplase and a transfer to us at this Comprehensive Stroke Center. Well, that was great. He got his alteplase, and that was perfect. We got our door to needle time just right. Unfortunately, he also had a clot in his arm, and so they elected locally to go ahead and remove that. In the meantime, because of that large vessel occlusion in his brain. He had respiratory distress. He had to be intubated, and the ambulance had to get changed. And then on arrival to the CSE, his LVO was still there. And now that aspect score was really low. And he had a big, large area of non-salvageable brain, and he couldn't have any treatments to us. So we didn't do very good on our door-to-artery or door-to-device times. So what AI can do is that as soon as the patient gets those scans, that the results go right to the mobile device, to anybody who's on it. And when that happens, it goes up to the cloud. Now the ED provider, the radiologist, the neurologist, and the neurointerventionalist can see the scans at that time. And then you can even notify a transfer center if it's someplace else, or notify the team to come in to do this. What we do know is that it does have better scan to review times. It has better door to needle times. It has better door to artery and device times, better door to revascularization times, and those transfer times are better. It's so the evidence that AI helps out during an acute stroke workflow was enough that the American Stroke Association recommended that any stroke center have AI in their workflow. So just some key points and just some summary. One, early awareness and treatment still key to good outcomes in stroke. And our whole management is to try to prevent worsened ischemia. So saving that ischemic penumbra. Our guidelines and interventions are evolving, and we use advanced imaging to make these decisions. And I think that RTs are really vital for optimal stroke workflow because all of the imaging that goes into that. And our post-acute stroke management is aimed at preventing any further strokes or secondary stroke recurrence. And AI is proven really to decrease time to treatment and improve outcomes. And again, is now a stroke recommendation for facilities. So thanks again for interacting with me today and for listening. If you have any questions, you can put them in the Q&A or in the chat. Or if you think of them later, you can email us at education.training@viz.ai. And then we have a few other courses. We have a couple that are in depth on CT perfusion by some really great physicians. If you're interested in that, if you know some nurses that would like some CE credits, we have them in ICH. We have stroke for nurses and subdural hematomas. And if you have, we really appreciate your feedback and have started some new sessions just based on that. So thank you in advance for that. And I'll hand this over to Vivian now to talk about your CE completion certificate process.